All right, another Thursday. You know what that means? We've got what, 6 studies on the docket today. And I think tonight's going to be a bit of a quicker night. So let's go through these. I'll give you my thoughts and hopefully you take away something from it. So the first one, the comparative effectiveness of progressive relaxation training on pain, well, pain characteristics, attack frequency, self-efficacy, and pain disability in women with episodic tension type headaches and migraine. What is this really saying? Well, if we try and implement a way for somebody to try and relax in a controlled manner, a progressive relaxation training, what they found is that it had pretty good results in both headache categories that they studied, because remember, they studied both tension type headache and migraine. They are two distinct things. And if we work back from the conclusion to the results, this training showed positive effects on the pain intensity, headache attack frequency, their activity level and self-reported self-efficacy, and pain-related disability in both groups, more so in the tension type headache group. So if we actually take a look at their results, when they compared it, and they showed significant decreases in what it showed in the conclusion, a visual analog pain scale. So basically on a scale of either 0 to 10 or very, very frowny face to very, very happy face, where are they at? And different headache specific questionnaires in both groups post-relaxation training. Both groups showed an increase in another questionnaire proficiency score, and the between group comparisons showed that the attack frequency and all the parameters that they were measuring were lower in the migraine group than the tension type headache group. However, the subscores were higher in the migraine group, which is where they got that conclusion from. So what did they do for this? Well, they basically put them through, I believe it was bi-weekly training. Let me take a look here in the methods. They were measured twice a week for 6 weeks. So not too terribly long. They were put through this training over the course of 6 weeks, and they had some pretty cool results in something that doesn't necessarily have to be done by a practitioner. Once we educate you on how to kind of do this, it's something that you'll have in your toolbox should an episode happen, should you have a change in your current life environment, whether it's you're moving, your job stress is increased, decreased, you got a new job, fired, etc. Things happen where we develop these new episodes and triggers for these types of headaches. And if you have something like this that is really simple in your back pocket, that is showing good results, because pain is very complicated. I mean, I don't have time to go over pain in this video, but I mean, we have mechanical reasons, environmental reasons, nutrition reasons, chemical reasons, social reasons, a ton of reasons to develop or alter pain levels in our body. And even if we're thinking like, oh, it's a headache, it's caused from, I know it's because I have a tight neck. That may be a factor, but it's by no means conclusive of what could be factoring into your headache. Even if that may be the dominant mechanism or what you feel is a dominant mechanism, it's not all that's involved, which is why I like having things like this in the back pocket to work with patients, whether we're doing things in office, on our table, different treatments mechanically, different exercises to keep things mobile. If we're talking about sleep, diet, lifestyle, to start to affect some of those other factors, I can incorporate this to try and start calming things down and give you something to do to kind of set a routine and a pattern to take the edge off of those headaches. Now, another thing, if we're talking about in-office treatment, a dry needling for tension type cervicogenic or migraine headaches, so 3 distinct types of headaches, a systematic review and meta-analysis. So the methods were just systematic review. They went through various databases and put them through different equations and parameters that you would for these types of studies. They had almost 3,000 studies identified, and they utilized 11 trials that were eligible for their synthesis and 9 meta-analyses, but they did say only 4 in the ones they selected were high quality. Now, I'm going to tease a few things out in the results because I think they're interesting. First up, if we look at this verbiage, very low quality evidence, so basically not the greatest sort of stuff, suggested that dry needling is not better than other interventions for improving headache pain intensity in the short term with tension type headaches. So you're thinking, great, dry needling, it's garbage for that headache. Well, not necessarily based on that verbiage. So first up, it's not better than other interventions. So we have to take a look at those other interventions as far as pain intensity. To me, that's not a negative for dry needling. It's a positive for the patient because we get to select a treatment intervention based upon the patient's comfort level, what they've had in the past that they know works or know doesn't work. And essentially, we get to then customize treating a patient for that type of headache with a wider range of treatments, because saying it's statistically no better is also saying it's just as good as other treatment options. So it's not something that, oh, dry needling is automatically better, therefore I'm going to push it on my patients. No, that's not what this is saying. This is saying it's no better, which means I get to allow the patient and I to collaborate and discuss which may be the best option for them in regards to this intervention. So the way it's worded is first a negative, but when you actually look it out and break it out, at least as far as my perspective goes, it's actually a good thing. Tension type headaches or mixed headaches, dry needling provided significantly greater improvement in disability in the short term with these patients. So now here's part of the conversation. So that same tension type headache, we say if pain is your main goal, then we get to employ any treatment that we discuss is the best for you. However, if we're doing a task that requires a lot of neck mobility, which maybe we tend to lock up when we have these types of headaches, if that is a must because of your job, whether you have to use your neck for driving purposes, whether it's for safety purposes or something else, then maybe I can make the suggestion of, if you're comfortable with it, dry needling does seem to improve these related disabilities in this short acute stage. So those disabilities in other studies that I have seen include specifically range of motion. How well can you move your neck? So even if pain levels drop the same level, depending on the intervention, whether I adjust, cup, scrape, needle, whatever, if pain's not necessarily the goal, but we got to get you function again, then maybe I will say, if you're comfortable, let's try it. All right. But again, it's always collaborative. And that's what this, to me, that's what this evidence is showing, is it still lets me say, we can talk about it. The synthesis of results show that dry needling could significantly improve headache frequency, quality of life, specific spot tenderness, and, oh, look at that, range of motion in tension type headaches and cervicogenic headaches. So again, we have to talk about what's the goal of the treatment. If it's just pain, there's a lot of avenues, but if you're comfortable with it and there is a need to, this is chronic recurrent and we want to reduce the frequency. And if we have a job related task that you need to use your neck for, then maybe I can just say, hey, all of these are viable, but I might suggest dry needling for you if you're comfortable with it. And that's what the rest of this is saying. Now, if we're talking about headaches, this one's nice and short. Basically, no surprise, jaw disorders overlap with headaches in young adults. Initially in the data, it looks like women are affected more than men, but when you break it down for statistical significance, they make the conclusion that temporomandibular disorder, so any issue around the jaw here, and overlapping primary headaches was found in young adults, and it reported gender-specific associations between that temporomandibular disorder, psychological distress, and comorbidities, indicating its stronger association for men than women. But to me, it's one of those things. Let's take a look at the rest of the data, take that gender-specific stuff out. If we have somebody with headaches, and we also have some other check boxes in our patient questionnaires where they're not necessarily in the best headspace, even nutrition space and other spaces that aren't always mechanical or physical. A lot of the times these areas, because this whole region from the neck to the jaw to the eye, like everything, look, the human body is complex as it is, but this region as well has a lot of overlapping structures where it is no surprise to me whatsoever that a fair chunk of these people will also develop or have a temporomandibular disorder. And it's something that I've seen personally in clinic where we can talk about the chicken and the egg. Is it the jaw disorder leads to the headache to the jaw disorder? But for me, if I'm dealing with headaches, I am looking at the neck and the shoulder and the mid back. And then I'm also looking at, for some patients, the jaw, especially if they report some sort of dysfunction, whether it's a clicking, a popping, a lock, or a pain. And it's typically in that order. Now, if they have jaw pain, I am automatically incorporating the neck into my screening and triage, as well as probably my treatment. So if you come to me, it's like, yeah, I'm coming to you just for jaw pain, TMD stuff, because it's causing the issues, I'm automatically going to incorporate some sort of neck treatment, because it's often overlooked in resolving this, because the areas, again, are so close, they overlap. It's, to me, a no-brainer that we should just incorporate both. It's kind of like, you have shoulder issues, I'm automatically including the neck. You have elbow issues, I'm automatically looking at the shoulder and wrist. Like, we want to meet the patient's expectations that we're looking at the site of the issue, but we are complicated creatures, and I am not just leaving my exam and likely treatment to the spot of pain, because that's not how this works. We have to look at you as a whole person. What do we need to do? What things are involved, and build a plan from there. But I'm going to get on a soapbox if we keep going that route. So let's finish up with these last 3 studies. First up, a specific type of treatment, this ESWT, extracorporeal shockwave therapy. Basically, think of, you have a device, it looks like a wand. Typically, the wands are about, I've seen them foot and a half on average. They typically have a larger end that generates some sort of a force. And oftentimes that force is being, this isn't technically true, but it's a good mental image. Think of, you have a tiny, and this is only how some of them work, you have a tiny BB within a controlled chamber, so it can't go anywhere, but there's force being put into that BB, so it just accelerates extraordinarily fast to hit the other end of the tube, where it's going to create a shock wave from that site of impact, because you accelerate something super duper fast, it hits a wall, you're going to get a shock wave. Well, what they can do is they can then take that in a device and essentially expand it or focus it however they need, and we create a treatment modality, essentially a controlled acoustic trauma to a target area to try and modify the body's way, the way the body's healing the area. It's really weird how it works. Dry needling kind of does the same, or extracorporeal shockwave therapy. A lot of these interventions will actually cause a controlled micro trauma that the body has to respond to. If you think it's a bit caveman-ish or medieval, exercise is the same way. And you're like, whoa, wait, what? Where is this coming out of left field? Well, exercise, you are trying to put the body through a controlled stress, a controlled breakdown. You shouldn't ever really get stronger within a workout if you're working out hard enough. Like, you know, if I do 4 sets of very hard, pick any exercise, squats, bicep curls, etc., I'm not typically able to do a ton more. Like if I do 100% of my max weight possible, one rep max, I'm not going beyond that. My body is breaking down from there. But in response to that breakdown, the body goes through a triage and goes, oh crud, if that's in our future, we have to be better able to handle that. So it's going to get stronger, lay down more muscle, make myself more efficient to do the task, etc. Same thing with this. We create a controlled trauma that the body responds to. I believe it's called a heuretic. Where now that controlled trauma, the body's like, whoa, what's happening? It's going to restart, amplify, or modify the healing response to an area to accommodate for that controlled trauma. This is one of those treatments where if you need to feel something to believe it's working, this is a fantastic one, because very oftentimes you feel it. You really, really do. There are others where you don't, like whether it's low level or high level laser therapy, especially non-thermal or non-thermogenic. You don't feel it. And some patients like, I don't know if I'm getting any better. This one you do feel. And what are they using it for in this study? Well, they're looking at it as a type of facet joint pain intervention, conservative facet pain intervention. So what's a facet joint? Essentially where you have the spine is sitting on top of each other, you have the discs, but you have other parts that interconnect. And if we think of the spine, I wish I actually had mine in front of me. This would be easier. Well, anyway, think of it this way. If this is the body, we have a disc below, a disc above. We essentially have the two parts of the vertebra connect together right in this area. And the fancy term is zygapophyseal joint, but it's also the area that we can layman's terms, the whole capsule area, call it the set joint. It sets together. And this can typically be an issue, especially if people try and bend backwards. There's a lot of inflammation in the area, and it can be debilitating because it doesn't really allow for a lot of movement for people that are going through it because it just sucks. So what did they do with this? They wanted to take a look to see if this randomized sham-controlled trial, if extracorporeal shockwave therapy could be included as an intervention. And I'm kind of surprised it can be. So they took a modest amount of patients with a confirmed lumbar facet syndrome by a medial branch block. So they actually blocked a nerve to see, hey, the nerve going around this area, if we shut off the pain signal, does it go away? Yes. Okay, they have facet joint pain. They were randomized to either receive the extracorporeal shockwave therapy at this intervention, 5 weekly sessions, or a sham therapy, and they measure their pain intensity, their stated disability, and other pain features at 2, 6, and 12 months. So they actually looked out a year. They also, this one's kind of cool, did a lumbar spine MRI baseline and 6 months post-treatment. Why is that cool? Let's take a look at the results. So the group that got treatment showed significant pain improvement scores at 6 and 12 months, a 64% reduction at 12 months. Their disability was self-reported decreased by 40%. And group A, compared to the sham group, the disability was decreased 42.3% in group A compared to 12.5% in the sham group. So a noticeable difference. Neuropathic pains symptoms improved significantly only in group A. And here, MRI follow-up demonstrated resolution of bone edema in over half of the patients treated versus none in the control group, with no adverse effects reported. To me, that's really, really cool. Like, astoundingly cool. In fact, this treatment modality is one of 3 that I've considered for the office. However, we need a little bit more disposable income to drop on one of these machines. So if you happen to be watching this video and you want this device in my office, by all means, I will accept donations. These aren't cheap, but they are effective. Shameless plug. I should put like a GoFundMe here somewhere. But anyway, I digress. I'm getting off point. What is cool though is now, until I get the device myself, I know providers that have this. I now can figure out if somebody has a chronic issue that's going to take a lot of time to resolve, I can now co-refer, like, hey, get this specific treatment because it's going to help what we do for this condition. It's awesome now that I have it in my mind, in my back pocket. It is safe, effective, non-invasive for that specific condition, showing sustained improvements in pain, function, and neuropathic symptoms. And if there is any edema or swelling in the bone, this has a chance to help resolve that. It's very, very cool. I like this a lot. I also don't like it though, because now it makes me question about if we actually get enough disposable income, which route do I go? But again, that's a my problem, not a you problem. Now, short one, then one where it's the study itself is shorter, but I can maybe rant a bit. Association between muscle strength and low back pain among middle-aged and older adults in a cross-sectional study in China. What did they do? They looked at almost 4,000 individuals. No, they looked at more than that. Where is it? Oh yeah, 11,000 final participants in a cross-sectional research designed study. They said that 4,000 of these individuals had a history of low back pain. And in those individuals that had low back pain, they displayed lower levels of muscle strength in comparison to the control group. They basically did a bunch of different equations to it and said that there is a significant association between decreased muscle strength and higher risks of low back pain among study participants after accounting for all covariates. Now, a couple things. This was in an older demographic, so we just need to make sure that we're specific about what we're talking about. And this is a correlation, not a causation, but it is strong, and it's one that I've seen backed up with other studies. Is strength automatically going to exclude you from getting low back pain? No. Is this, if you're stronger, you're automatically not going to get low back pain? No. If you are weak, are you automatically going to get low back pain? No. However, the odds are greater, and that typically means on both ends of the spectrum. If you're kind of like the bone study last week, if we are too weak, we typically don't have the capacity that when we run into something that our body has to do, that demand will be more apt and more likely to trigger a pain response because we are not built up to handle it. The people that have adequate muscle strength can cope with it, and the people that have too much strength in the regards that when you train at such a high level, it's like a very, very fine-tuned engine where now if we're not giving it the best fuel, the best recovery, et cetera, we can damage the engine. So a very, very high-end athlete is also at a predisposal to pain for different reasons. So this one is adequate. Like if you have the mean, good, healthy level of strength that they measured by association via a grip strength dynamometer. And it's not just because, oh, if I train my grip strength, I'm automatically going to be, no. This was a, related thing. Like you can't do different activities without having typically a good grip strength. So it's just a marker by association that they looked at. Hopefully that it didn't confuse anybody. I've got different talks on grip strength that I've done before, but I'm not going to get into it now to keep this video purposely short. Long story short, it's a fantastic correlation that I will bring up. I'll talk with patients about it, but not as the promise of if you get stronger, this pain will go away. It's one of those, you'll have more resources at your disposal to handle the things that would cause somebody else to have back pain in that situation. And I'll leave it at that. The last one, and I'm going to try and keep this really, really short because I know I can go off on this. The challenge of diagnosing patients presenting with signs and symptoms of subacromial pain syndrome, so kind of in the shoulder region, a study of 741 patients seen in a secondary care setting. Basically, this can get wordy, this can get confusing. The results were typical, I'd say. We can treat the verbiage of subacromial pain syndrome for a lot of other pain syndromes, non-specific low back pain syndrome, diffuse pain syndromes, chronic pain syndromes. Basically, one of the things that I do pride my office on, and when I work with patients, is diagnostics, just because we do take the time to try and really get through the weeds and figure out what's going on. But we also must understand the complexity of the human condition and be ethical in how we discuss and diagnose things in the office. And what I'm basically saying is what this study is also saying, is that oftentimes, just like with pain as a whole, there are a lot of co-founding and overlapping diagnoses and symptom drivers or frankly, other diagnostics that could be involved with this patient. It is very rarely a singular diagnosis that a patient is going to get. So if I can try and tease this out from the research vocab here, they screened a bunch of patients where they wound up with 576 had signs of subacromial pain syndrome. Of those, 168, 30%, had conflicting diagnoses with things like frozen shoulder. The remaining were just diagnosed with subacromial pain syndrome, but of those remainder, they had at least one other concomitant diagnosis. And some of them, 13% of them, had multiple concomitant diagnoses. In total, 22 different combos of diagnoses were observed across just 172 patients. The reason that I can get off on this is 2 to 3-fold, but I'll try and keep things brief. One is I will still use verbiage like the root cause, but I will then, take a look at a root system. Yeah, here's the root that's pissed off, but here's the others that we have to take a look at. So I will still use that verbiage because I think it's easy to discuss with patients as a whole. Others will use it as this is the only thing we need to look at. This is the only diagnosis, thus this is the only thing we need to do. That is not how people work, and that is not how diagnostics are accurate. Even when I'm doing orthopedic testing, there's sensitivity, specificity, there's a bunch of parameters. And if you do one in isolation, the odds of you being accurate for that orthopedic test are almost negative. You have to do multiple orthopedic tests to hone in on a diagnosis that is relatively accurate in some conditions. I'm going to say that it is very accurate, or can be very accurate for some conditions, not all. The point of a lot of these tests are screening tests, frankly, because there's very few that will hone in just to one diagnosis only. And oftentimes it will be kind of similar to how I have this talk with pain, where, hey, look, today it seems to be the main diagnosis or the main issue is X. I'll do my best, or we'll work on this, and maybe then we can tease out something else that is going on if it's there. You know, like with low back pain, hey, right now it seems like you can't do X, Y, and Z. We're going to treat that. We can leave it as a blanket of non-specific low back pain, which I'm more of a fan of multifactorial back pain. To me, it just makes more sense in my brain. And yes, mechanically, maybe this tissue is more involved right now, but, you know, give it a couple of weeks, maybe the tissue involvement will switch once we're changing it from, yeah, maybe it's bony, now it's more muscular, and now the remainder of your pain is, you know, chemical because you're eating like a campground raccoon, and I can't, well, I can coach you through it, but without your help, I can't fix that. And you know what, maybe you've had terrible sleep for the past 3 weeks. I can't do anything about that other than coach you on what to do and maybe recommend a few relaxation techniques and supplements if you're excessively stressed. Basically, these are concomitant factors that are involved with a diagnosis. So I guess I'll end it on this so that I don't get too preachy. If it is my ultimate goal to be people-centered and not, if my goal is to be people-centered in treating people, I therefore cannot be disease-centered treating a disease. So I cannot try and look at and isolate every single time with 100% accuracy, no matter what I do, to a singular isolated diagnosis, especially when so many things overlap, given how interwoven and complex we are as individuals. What I can do is isolate it down to what is like a triage system, or let me back up. I can triage it and say, given what you've got, I can, in my experience and based on these parameters, make the educated assessment that this is the most likely right now as of this date. There are ways that we can treat it if we don't need additional tests or imaging. Sometimes it's we'll treat it for 2 to 4 weeks, and if it doesn't get better, then we test for other parameters. But I always let my patients know that this is the most likely at this point in time. There are other things here, and I often tell them, I'm considering this, and this as well. What really comes down to, does it change my treatment approach? So very oftentimes these overlapping conditions don't always change my treatment approach, and I'll tell the patient that, hey, it's this, maybe this and this, doesn't change too much. So to me, it doesn't matter now that I've got it to a direction, like my diagnosis accuracy, or what I consider an accurate diagnosis is giving the patient a treatment path that makes sense based upon the parameters that we've discussed and gone through and found out. It's when that hits a wall that we need to readdress, and it may be one of those other co-founding or co-committant things that has a different prognosis and requisite treatment requirement. Like let's take 2 shoulder patients that I've had in the past couple months. One, full-blown dislocation to the point where there was cartilage material in the joint space. That's a surgery requirement. The other, chronic recurrent shoulder dislocations without cartilage involvement in the shoulder that we can address conservatively. There are other parameters that I'd have to consider between ligament laxity, other autoimmune conditions maybe can affect joint structures, especially with pain depending upon their age. There's the fact that in the full-blown acute shoulder dislocation, I have to consider fracture, which there was almost based upon the image study that they did. There was tissue damage, there was articular damage, there was a bunch of things that even within that diagnosis of shoulder dislocation made it vastly different for that individual than this other individual who does have dislocated shoulders, but the two treatments vary widely. And that is just within a singular diagnosis itself. Not to mention if we go into something that even in shoulder pain, yeah, lots of things that it could be that overlap, and patients can get slapped with a diagnosis that they claim they have, or maybe they do, maybe they don't, maybe it's overlapping, maybe it's not. This is why we always want to be talking with the patient, building rapport and figuring out what is truly going on. Is it what they were labeled as? Is it something different? Do we go after and try and change their perception on that label, or do we not? Does it play a factor into their care? I'm starting to get preachy. Told you I could. Long story short, this could be any part of the human body, any syndrome, any condition, non-specific low back pain, shoulder, even a singular diagnosis, like I gave an example of two patients. What really comes down to is your diagnosis giving the patient and you a direction to actually pursue. Do you understand the prognosis of the conditions that you're considering? And then are you able to guide your patient through that anticipated prognosis in an ethical, effective way that is satisfying to both you and the patient, and able to pull a lateral if need be at that given point in time, because there can be overlapping diagnoses. That's the important thing that you need to have in clinical practice. That's what I'm going to end on, because I can really just keep going here and probably confuse the bejesus out of half the people watching this. Maybe all. Like, give me long enough, I won't be making sense anymore. So thank you for putting up with me this far. I look forward to next week.